Good morning, Dr. Nupur, and good evening to all my friends in India. So today another one, journey for all of us, and it's an interesting topic. As Dr. Nupur was telling, we are going to learn quite a lot on this bispecific T cell engagers. And today, Dr. Bahu Sahib and Dr. Niraj will be conducting it. Both of them are from Tata Memorial Hospital. Of course, our international expert will be Dr. Nupur Raje. So without any delay, Dr. Lingaraj, you can start your presentation. Nirav, you can share the slides.
Yes. Thank you. Das sir, and thank you, Image, for giving me this opportunity. I think you have to make it, yeah, slides on. I think, Nirav, you have to keep it fit to the screen, I guess, fit to the window, then it will be.
It's proper, Lingaraj.
Okay, I can see it. Thank you. Okay. So the topic for today's Journal Club, the title is Pre-Existing T Cell Landscape Determines the Response to Bispecific T Cell Engagers in Multiple Myeloma Patients, and the title is quite explicit about what we are expecting from this paper. Is that what they have looked into is what are the pre-existing T cell repertoire that determines the response or the resistance to bispecific T cell engagers. Next slide, please. Yeah, so as this is a paper which deals mostly the basic and translational science about T cell biology, I thought I will just keep a couple of slides about basics of T cell response in malignancies per se, be it lymphoma or myeloma. So what do we mean by effective T cell response is that whenever a T cell encounters any unwanted cell in our body, be it a malignant cell, be it a virally infected cell, so there is a certain amount of antigen presentation by the malignant cell, and that leads to activation of the T cells. So that is the first thing that happens whenever there is a malignant cell. And as if that is the only signal, then that can lead to energy of the cell. So that's why there is a co-stimulation attached to that. So we need two signals to activate a T cell, and we don't want the T cell to be active balances for the T cells, so that we have to limit the rate of activation, otherwise there will be more immune related problems. So that CTLA4, TIM3, LAG3, TZ. So these all are negative immunity, so to say. And then there are steps of persistence and memory T cell that we see subsequently in a T cell response. Next slide, please. Yeah, so how does cancer evade this T cell response? So there are basically 4 different mechanisms. And first is when there is loss of antigen presentation, mostly because of loss of MSC expression. And there are 3 different kinds of suppressive signals that somehow suppresses the T cell functioning. That can be either a suppressive ligand in the form of PD-L1, LAG3, and TIM3, or suppressive cell population in the tumor microenvironment, that is Tregs or MDSs, or suppressive cytokines that are released from the monocyte necrophage system, that is IL-10, IL-12, or TGF-beta. And this leads to something called as exhausted T cell phenotype. Next slide, please. Yeah, so what do we mean by T cell exhaustion? So whenever there is Tregs, there are inhibitory cytokines and there are inhibitory ligands, that creates a state of dysfunctional T cells, which may not be that effective in terms of its activation, persistence, or cell killing. And that leads to something called as exhausted effector T cells. And that is important when we are talking about T cell engager based therapy. Next slide, please. Yeah, so T cell engagers, that is the BiTE specific therapy, it overcomes few of the challenges that I have discussed in previous slides. Basically, it links 2 different cells by the 2 antibody fragments that recognizes distinct epitopes on the tumor cells and as well as T cells. But still we see resistance, and is the resistance pattern in this kind of therapy, that is the T cell engager therapy, is any different than we see in other immunotherapies? and what is that resistance at what level, and is there any other mechanism that plays around. That is the basic purpose, and that is the basic intent of this paper that you're going to see subsequently. Next slide, please. So myeloma as a model to understand this is very unique, because myeloma is a disease where the plasma cells, the tumor cells are very closely associated with the marrow immune microenvironment. So you can basically you get the tumor cell and microenvironment very closely related with each other in the bone marrow. You can do serial bone marrow aspiration and biopsies to understand the interactions that happen subsequently. And one interesting thing is that you can do the bone marrow studies from the same site, which are marked in the iliac crest, to avoid those intra-individual variations in the microenvironment that you can see in other tumors. So that's why myeloma becomes a very unique model to understand this interaction. Next slide, please. So now coming to the technique that we have used is single cell RNA sequencing and immunology. So single cell RNA sequencing is something that has really revolutionized the way we understand immunology in any cancer. And I will just allude the basic steps that a single cell RNA-seq does. And there is something called clonotype mapping that they have used in this analysis. So what in single cell RNA sequencing does is that we take a tissue sample, and you do first thing is isolate the single cell. So there are multiple steps. How do we isolate those single cells? And then you do the sequencing. After that, what you get is transcriptome, or that is the transcriptome of each cell in the microenvironment. And then you put it into a bioinformatic tool, and that will analyze and tell you that what are the characteristics of tumor microenvironment, what are different kinds of cell. Interestingly, you can identify novel cell type that you have not yet discovered, and you can also see the interactions between them. And also you can see the linear trajectories, that what happened to those cells, how do they differentiate further. And what is a clonotype? Clonotype is a TCL receptor clonotype, is a unique nucleotide sequence that arises during the gene arrangement process for that particular receptor. So you can, so a certain group of T cells will have a certain type of clonotype, which is unique to that set of T cells. And you can, if you know that set of mutations, you can track those cells in the different compartments of the body, be it peripheral blood, be it marrow. So to understand what happened to those cells when the patient progresses or the patient responds, what is happening to those clonotype of T cells. So that is basically called as clonotype mapping. Next slide, please. So this is how they did the study. So they have taken 5 bone marrows from the healthy bone marrow. 7 are newly diagnosed multiple myeloma. 18 are relapsed refractory multiple myeloma. So they have taken both from the peripheral blood and the bone marrow. So as you can see, they have taken samples from the 3 different time points. One is pre-starting therapy, then early, that is after first cycle of T-cell engagers, and late, that is after 4th cycle. And they have done flow cytometry, they have done single cell RNA sequencing, and they have done deep sequencing in the VDZ region. And they have also done the functional assays of those genes, that is knocking out a gene, how it affects the functionality of the cell. So that also they have done in this study. And finally, they have done the mapping of those, as I said, the clonotype mapping, to understand what happens when you give a T-cell engager in terms of the response, or in terms of if they don't respond, what happened to those T cells. So you have 30 samples here. Next slide, please. Next slide, yes. So total 30 bone marrow samples, and you can see here the time points that they have shown here, pre, early, and post. So early is after 1 cycle, post is after 4th cycle. So they had transcriptome T cell repertoire of bone marrow associated immune cells, and they have done it longitudinally as well. And these T cell clones are traced over time using the T cell amino acid sequence as individual barcodes. So each unique T cell amino acid sequence will act as a barcode, and that will identify them, the same cells, whether they are in the marrow as well. Next slide, please. So after stringent quality control and filtering, there were 3,25,000 bone marrow immune cells were obtained in 30 marrow samples, and they were then grouped into 63,000 distinct clonotypes by matching their alpha and beta chain pair, and also they are matched with the peripheral blood bulk of TCR beta sequencing. So this will now allow us to track the clonal lineage and measure the overlap and dynamics of each clone, that is single clone in the bone marrow and the blood. Next slide, please. Now coming to the results. Okay, so first thing is Tregs. So Tregs, as I already discussed previously, that is an important immunosuppressive signal in immune therapy. So here the Tregs are not increased. So that is important to note here. And what they have found is that at relapse, there is increasing CD8 and decreasing CD4. So there is an altering of CD4, CD8 ratio. You can see from this diagram here in the D. So you can see that the Tregs are not increased at all. And you can see the altering of the CD4 and CD8 ratio in the lower part of the curve. So now CD8 clone or CD8 T cells were two different types based on their granzyme K expression. So there are a group of cells which are expressing granzyme K. So that is GZMK plus CD8 cells. They express markers of T cell exhaustion, that is PDC-D1 and LAG3. Whereas those cells are mostly present in patients who are in relapsed refractory myeloma at variable frequencies. Next slide, please. So now you can see from this this graph that what they have looked into, what is the trajectory of CD4 and CD8 cells, and specifically the group of CD8 cells called as CX3CR1 group of CD8 effector cell. What is the trajectory in patients who are responding to treatment versus those who are not responding to treatment? So what they found, you can see that the CD4 memory cells, so there is a significant decline whenever there is a response. You can see here in the patients who are responding, there is a significant decline. But if you see here in the CD8 effector cell, which are CX3CR1 expression, they have significantly increased in those patients who are responding. You can see here in the response, in the responder, R stands for response and NR stands for no response. The patients who are responding, there is a significant increase in the CD8 effector cells. And in response, that is very consistently they have found. In non-responders, there was a mixed response. You can see here, those some patients, there is increase in CD8 cells, but most of the cases, there is kind of mixed response. Next slide, please. That CD8 cells are increasing in the marrow. Okay, the CD8 effector cells, which are typically expressing a particular phenotype. So from where these cells are coming, whether the cells are coming from the peripheral blood and homing inside the marrow, or is there any kind of phenotypic shift that is happening in the marrow from the naive T cells? Next slide, please. Next slide, please. Yeah. So to understand that whether there is a homing phenomenon or there is a phenotypic shift. So phenotypic shift meaning the change or the modulation or kind of the shifting of naive cells to the effector cells, or else that effector cells which are already present in the peripheral blood, now they are coming to the marrow by a process of homing. So to understand that, they have done deep VDJ sequencing on the matched samples of bone marrow and peripheral blood. So what they found is that post-therapy, they could see some kind of concordance by clonotype matching, that the group of cells which are detected in the peripheral blood, the same group of clonotypes are also detected in the patient's post-therapy. And also they have found there are certain naive CD8 cells which are there in the form of naive clusters. Now after treatment, now they have transformed into memory and Treg. So there is some kind of diversification that is happening on the same clonotype. So that indicates a degree of differentiation that is happening. And at the same time, there is also homing phenomenon that is happening from the peripheral blood. Slide, please. Yeah. So now what they looked at is there any difference in the phenotype of CD8 exhausted T cells in patients between those who responded versus those who didn't respond? So what they found is that they have divided into two groups, above median and below median. And what they found is that patients who didn't respond, they had a higher levels of CD8 exhausted T cell like. So that is the basic biology, is that if your T cells are not good, they are already exhausted, those patients probably are not responding to T cell engager based therapy. But they have done this analysis for patients who are receiving anti-BCMA CAR T cell therapy. But they didn't find this kind of correlation that they found in this particular paper, that is in the T cell engager. So probably this kind of different response in exhausted T cells are very unique to T cell engager therapy as opposed to the CAR T cell therapy. Next slide, please. Now I discussed in my first slide about the loss of antigen expression. So BCMA is the antigen that is the target antigen in most of the plasma cells, and that is there as a part of T cell engager therapy also, or the CAR T targets also. But we have to have an MSC guided expression or MSC mediated antigen presentation. So is there any loss, or is there any loss of MHC1, and that is leading to loss of antigen expression, and that can actually lead to primary resistance? So what happens is that when you give a T cell therapy, the T cell exhaustion can occur after repeated rounds of T cell engager therapy. So if you give multiple cycles of BiTE cell therapy, your T cells get exhausted, and that is the process. But we therapy. So what is happening there is that is there any primary resistance mechanism that can explain this? Is the loss of MSC1 blockade? So what they have done is they've co-cultured the T cell, the plasma cell, and the T cell engager, and an antibody which is going to block the MSC1. So what they found is that if they're not using the MSC1 blockade, there is a good expansion at the time point T7. But when they are using an MSC1 blockade, you can see that the expansion is decreased. So what they found is that probably this is also one of the mechanism of resistance where the loss of MSC1 that leads to kind of primary resistance to T-cell engager therapy. Next slide, please. So to conclude, there are two important modes of resistance that you have seen in patients who are not responding to T-cell engager therapy. First is express the CD8 cells which are expressing this granzyme K, and they also express these exhaustion markers which are LAG3 and PDCD1. So this is a kind of CD8 cells which is a negative predictor of response to the T-cell engager therapy. And the second important predictor was loss of MSC1, which is one of the potential mechanism why there is loss of target, which is beyond the loss of BCMA. So you can see in this cartoon very nicely depicted in the left side, the patients who have responded to T-cell engager therapy, they have a good kind of T-cell. You can say they have the non-exhausted group of affected T-cell. They have good MSC1 expression, so that's why they're responding. But the patients who are not responding to T-cell engager therapy, there is a loss of MSC1, and there is a group of phenotype of T-cell which are different and which are exhausted like T-cell clones. That's why they're not responding in the manner. Next slide, please. So what is the clinical implication what I could make out from this reading this paper is that first thing is what I have depicted is that what they have depicted is that the kind of response to treatment based on the phenotype of T cell is very unique to T cell engager, but was not seen in CAR-T. So now, is this the future that can we use this kind of technology and to understand, to decide between a CAR-T or T cell engager therapy? That is something which came to my mind, that is this a way to choose between the two kinds of cellular therapy. Now, second is modulation, different mechanism which can modulate and can increase the MSC1 expression. So there is something called immunogenic cell death. There are drugs which kills the tumor cell and it creates something called as immunogenic cell death. Now, when there is immunogenic cell death, it sensitizes tumors so that they have more MSC1 expression. So typically in myeloma setting, you have bortezomib, you have carfilzomib, and you have in addition to the extramedullary disease, and that can express or that can upregulate the MSC1. Probably that can take care of some aspect of resistance to T-cell engager therapy. So these are the two ways which I can look at, which it can help or it can have some kind of clinical implication. So with that, I thank, and next slide, please. So thank you, organizers, and thank you once again. And I'm happy to take any questions. Thank you.
So I can get started. Lingaraj, that was a difficult paper which you put really nicely into perspective. And I think all of us learned from it. So thank you. And giving a little bit of the basic biology was so important, so that you can bring everybody up to speed. This is something which is the future, which is why I wanted us to discuss this paper. We're using a lot of immunotherapies in the clinic right now, but unless you understand the basic biology of this, it's going to be difficult for us to apply. So the two things that you pointed out are perfect. In addition, what I would suggest is when you have those exhausted CD8 T cells, and you've shown so nicely, increased LAG3, for example. So this is a place where I know checkpoint inhibition was not something which was useful in the context of myeloma when we first used PD-1, PD-L1 blockade. But in the context of immunotherapies, I do think there's going to be a resurgence of use of some of these. We have anti-TIGIT antibodies, we have anti-LAG3 antibodies, and whether we can do them in concert. The other concept which you brought out so nicely is this lack of MHC, class 1, MHC1 going down, and this whole concept of immunogenic cell death. So you brought up two of the issues, carfilzomib and bortezomib causes that, but what is becoming increasingly understood and appreciated is drugs like daratumumab, CD38 monoclonal antibodies, also cause immunogenic cell death. And you have some of these trials, TRIM2, a lot of the elranatamab trials, as well as teclistamab trials, are combining the anti-CD38 antibody, and it could actually be overcoming this loss of MHC. We don't know the mechanism. As we do these, we are collecting samples, and this is something which needs to be studied as well. So, we are seeing 100% response rate. Well, I think what this allows us to do is how can we overcome the resistance? And if you really have an exhausted T cells, it's not surprising that we should be using something else like CAR T cells. So understanding the T cell biology is important. One last thing that I'm going to mention, which was really important in what you touched upon, is, you saw some homing of the peripheral blood immune signature with the marrow immune signature, but it was very similar in the peripheral blood, right? It was not
Yes.
that different,
Yes.
which then suggests to us that
Yeah.
we don't necessarily need to do a bone marrow to look at an immune signature, especially when they're on treatment. And can we use peripheral blood alone as a biomarker for us to try and understand the immune landscape while patients are on these? So thank you for doing that. I'm going to ask you to send me your slides because I really love them. Thank you.
Thank you.
Yeah, Dr. Bausaheb, your comments.
Yeah. Yes, sir. So I think I agree with Dr. Nupur. This was really made simple by Lingraj. The paper is quite big. I think it's 21 pages, but he has put it the gist of it in front of us. And really, it's time that we look into this kind of drug. We are having a lot of responses. We are across that 20-30 range in the relapsed refractory setting now, and we are reaching 60. But still, that 40% they don't respond. That's a primary resistance. I think this is where this paper comes handy. And last couple of years, we are seeing repeated oral presentation on this topic. But no, the solution which you suggested were also very good. But it looks like all the drugs will work in synergy with T cell engagers. So Dr. Nupur, you spoke about daratumab. It looks like IMiDs also would be synergistic. So what do you think would be the best partner drug? Because we have combination trial lineup, Majestic 7, Majestic 9, and n number of trials.
Yeah, so those are great questions. And what we are doing right now is in combination. So we are using elranatamab and teclistamab in combination with pomalidomide. The confirmatory trials are all in combination with POM in the relapse refractory setting. If you think about it, using an IMiD is going to augment the immune function and hopefully decrease the CD8 exhausted phenotype. We are also doing some of the other combinations. So what we have ongoing is we do have the anti-CD38. We're just going to open up a trial with isatuximab, for example, with the elranatamab, and we will be studying very similar things which you've shown us so nicely here to confirm specifically the immunogenic cell death. We are also combining it with carfilzomib. So I don't think the jury's out there on what the best combination partner is. One thing that we have seen, though, is a slightly increased, when you start using these immunomodulatory drugs, the IMiDs in combination, we did see early on a little bit of a neuropathy signal. All of these bispecifics can cause that. With the anti-CD38, I think our biggest challenge, although we are seeing 100% of a response rate, I think the bigger challenge there is the infection risk. So, I think the sobering thing out here is understanding the mechanism is a good idea, but for the future, trying to minimize the toxicity. And I think the biggest toxicity for the bispecifics right now, in our opinion, is the infectious signal that we are seeing. And when we start combining, we're going to see more of that infection. We may overcome the resistance, but we might end up seeing more toxicity. So it's a little bit of a balance. We're doing sort of umbrella studies. I personally like an IMiD, and if we can use some of the newer IMiDs, so the CELMoDs, for example, in combination, I think we'll be able to go a long way. I also think we should be combining with the checkpoint inhibitors, just based on everything which Lingaraj has shown us so nicely.
Yeah. And Lingaraj,
Dr. Nupur, on this, what Dr. Bhausar was telling, I exactly don't know much about this immune signature. Can in myeloma, if we get an immune signature in the beginning or at the time of diagnosis, we somewhat can predict how the outcome is going to be or what kind of a combination drug it is going to respond. Can that be done with this, kind of bispecific T-cell engager taking into account?
Yeah, no, I think, that's a really good point. What we are, so the newly diagnosed space we're just looking at. So what we've done is just looked at T-cell function, and we've looked at T-cell function, and we've not yet published, but hopefully we'll publish very similar, looking at single cell sequencing. We've done ATAC sequencing, and we've looked at the transcriptome. So we've taken healthy donors, newly diagnosed myeloma, and myeloma after 1 to 3 lines of treatment. And what we've seen is even at the newly diagnosed stage, the immune signature is different. You're already seeing a fair amount of immune dysfunction in patients. But I think if we can predict who are the ones who are going to respond versus not, specifically when we have so many different treatments available to us, I do think this is going to be how we're going to treat people in the future. We don't have the data as yet, though.
Dr. Pankaj?
Yes, Pankaj sir.
Yeah, please, Dr. Bhausar, go ahead.
No, sir. I think we'll have Pankaj sir too. Pankaj sir, if you want.
Maybe I think Dr. Arun has raised his hand.
Yes,
so let
Arun,
him ask the
please.
question. I'll ask later.
I didn't see that hand. Okay. Okay. Arun, you can go ahead.
Yeah, so I have 2 queries. The first question is for Lingaraj. This is regarding, did we actually study in that article whether people who were responding and had a T-cell non-exhausted phenotype went on to develop a T-exhausted phenotype because of continuous bispecific stimulation? That is my first query. Second thing is, thinking aloud and drawing parallels from ALL, where we use blinatumomab and give continuous infusions of blina and push the cells to T-cell exhaustion and then develop T-cell dysfunction. And having said that, we know continuous use of bispecifics are fraught with the risk of infection. Is it not the case to point about interrupting the treatment of bispecifics at periodic intervals rather than giving it continuously if you have to leverage T-cell exhaustion there?
Yeah, Arun, so from this paper, no, they have done at 2 time point after treatment, that is after 1 cycle and after 4 cycles. So what happened to those patients who were responding and what happened to them? I don't think they have done that analysis. So what they have looked at is patients who responded versus no response. But your point is very pertinent that those who responded, what happened to them subsequently, if you continue to give those, probably they also will go into that kind of phenotype and they will stop responding. So so that's the answer to your first question. So what was the second question, Arun? What did you ask?
Second question was about, like in CML, we talk about TFR, treatment-free or treatment interruptions.
Yes.
Rather than giving continuous bispecifics and driving T cells to exhaustion and increasing the burden of infections. The case in point would be treatment interruptions and then trying to rejuvenate the T cells which have an exhausted phenotype, at the same time reduce the risk of infection. That was my question.
Yes, I mean that's a valid point, and I think that's a valid point that comes out from this paper as well. I mean, Dr. Nupur can throw light on that.
No, I think, Arun, those are such pertinent questions. And, you're right, like Lingaraja said, they did only up to 4 months. I will tell you what we do in clinical practice. There are patients where we've had to take them off of the bispecific, and for infectious reasons, and they've had a continuous response. I do think constantly engaging those T cells, the phenotype of those T cells is going to change. and it is going to become more exhausted. And if you think about then, this is what you raise is very pertinent to sequencing as well, right? So should you be doing a bispecific before a CAR T cell? And the answer to that, if you're going to use continuous bispecific, not a good idea to pick a whole lot of exhausted T cells. So I think what you're bringing up is very, very pertinent. I think we are all looking at sort of fixed duration treatment with the bispecifics. Those are sort of ongoing trials. Less frequent dosing of the bispecifics also needs to be done, so that by doing so, we are going to be decreasing some of the side effects that we see with these bispecifics. So absolutely, I think that is what the future should be.
Thank you.
Yeah, exactly. That was, my question that, when you are giving these therapies, so is it a good idea to initially give some form of an induction therapy, and when you feel that the disease load is, low, and then, give this bite therapy so that, those patients remain in remission? That was the one question. The second was, what about the cytogenetics? So have we seen some differences with, somebody who has very high risk cytogenetics and somebody who has a standard risk? We know that, standard risk myeloma, generally they will respond very well to whatever therapy which you are going to give. Whereas those patients who have high risk cytogenetics, whatever therapy you are going to give, sometimes, that is not that successful. So is there any difference between the T cell responses in these two group of patients?
Yeah, so obviously the paper didn't address that, Pankaj, but this is again such a relevant question, because what we've seen over and over again with the CAR T cells, with the bispecifics, the high risk group remains high risk, and they tend to do badly. Now, is that because they've had a lot of treatment early on and they've had multiple lines of treatment by the time they come to this, and they have more of an exhausted T cell phenotype? We don't know that. The numbers in this particular study was very low. The other thing we've tried to look at in our newly diagnosed patients, and we haven't done single cell sequencing, I think we need to, is if a high risk genotype changes the immune landscape. And one of the hypotheses there would be a high risk genotype creates more of an inflammatory signal. And you talked about some of the cytokines, Lingaraj, and if those then predispose you to a more sort of a negative, exhausted immune phenotype, that's something which we are looking at in the lab. But that would explain why, even with CAR T cells and bispecifics, they do better than with standard treatments, but the high risk always remains high risk. That's one of the reasons why high risk disease, what we are doing with the CAR T cells is early clinical trials on them. And we'll see whether we are able to improve upon the responses. Pankaj, we still do not have data. The other thing which you brought up to me is actually really interesting, and the reason I say that is at newly diagnosed myeloma, should you be using this or should you use some kind of induction treatment to suppress the myeloma clone? I almost think, based on some of the work that we've done looking at these different signatures, because your immune signature is so different, even, myeloma is an immune disease, right? And the immune dysfunction happens at the time of diagnosis. So can we help fix that a little before we come in with these treatments? And the answer to me, that would be an interesting way of doing things. So, there are studies right now wherein they are doing, some of these treatments as a maintenance strategy, for example, and maybe we're going to get more out of that as compared to using it upfront.
Any further questions, Dr. Babu Sahib?
No, sir, nothing from my side. Just to add, I think 414 and one of the bites, it leads to overexpression of, I don't remember, BCMA or GPCR2. So there is some speculation that it might be more amenable to taclistamab or talquetamab. I don't remember, but that's just a hypothesis as of now. But very interesting. One thing which was different as Arun started Blina and this story, the down regulation of BCMA seems to be less here. Maybe it's because of intermittent dosing, etc. And surprisingly, the baseline load of immune suppressive cell like Tregs and myeloid-depressed suppressor didn't really come up as a predictive marker of response in this as opposed to other checkpoint inhibitors and other bites. But definitely, and I think a very important point suggested by Dr. Nupur was to do it from peripheral blood. I don't think we will be in any way in a position to do bone marrow before we give this drug, but looking at peripheral blood would be really useful, which is kind of available to most of us. So that's all from my side, sir.
Dr. Nupur, any further comments, or we'll proceed to the next?
No, proceed to the next. And thank you, Lingaraj. Thank you. It was really nicely done. And thank you, Bas Saib. It was really great. We all learned a lot.
Thank you, Dr. Nupur. We learned quite a lot. This is a very new subject to us. In India, we always look towards the patient management rather than going into research and details about it. Thank you very much in giving some insight into this particular mode of therapy. And Arun, you can start next.
Yes. So there's a question from the audience. So can we take on that question, sir?
Yeah, please.
So this question was about what will be the duration between two bispecific doses and how long can we continue? There is a question from Dr. Dilip Kumar, sir, in the chat box.
Yeah, I can answer that. So right now, depending on whether you're using TEC or LRAN, those are the only sort of furthermost in development. The initial dosing we are doing as a step-up dosing. So we're giving a small baby dose, and then 2 days or 3 days later, we give the higher dose. And by week 1 or 1 week into it, we give the full dose. Initially, they're getting once a week treatment. And then with both of these, we are going with LRAN also after the first 2 months. LRAN after the first 6 months, they're going to every other week. And with TEC also, after the first 2 months, you can go to every other week. I do think this question of dosing is still completely open. I do think less frequent dosing is completely fine. I do not believe you need to dose as frequently as both TEC and LRAN are doing. This was just the initial ways of getting these drug products approved. And the other, I think, which Baus Saib brought up, that issue of BCMA downregulation, which was not seen. Remember, this study was done only after 4 cycles, right? And over time, are we really benefiting a patient by constantly giving these T-cell engagers? We really don't know. And that's why doing a later time point for some of the BCMA downregulation, which needs to be done, they didn't look too much on the tumor cell. They were mostly looking at the T-cell phenotype in this paper as well. But some of these things need to be looked at the tumor compartment, and more work needs to be done around that. But over time, as we see with CAR T cells, you are going to see a downregulation of BCMA as well, right? The antigen is going to go down.
Nirav, can I have my slides, please, Nirav?
Yeah, please.
I welcome you all to this edition of the Eagle Eye competition. This is about the best commentary on a Journal Scan article. And the Journal Scan to be discussed was about the biallelic deletion of 1p32, which could define an ultra-high risk subset of myeloma. Next slide. So to briefly introduce the entire process of this Eagle Eye competition again for the benefit of people who have joined in late and new entries. Next slide, please. So we choose a recently published article on plasma cell dyscrasia. We invite your commentaries of about 175 words, at least a week before we start the process. Anyone who is interested in myeloma can participate. The degrees don't matter. The best commentary is actually selected by a group of blinded reviewers, and the person who is the chosen one, in addition to presenting this in front of an august audience here, gets the credit hours, the certificate and vouchers worth 5,000 rupees. Next slide. So what is the purpose of this? It's about getting to know about the latest in plasma cell dyscrasia, a critical appraisal of what is published in literature. You yourself refine the art of scanning any article. You could actually build upon this and write letters to the editors. And definitely you get an opportunity to present in front of the best in the field. And for some of us, it makes it a match of prestigious inter-institutional competition as well. Next slide. So we do analyze here. We have a stickler for the word limit, but we do analyze this submissions on at least 8 accounts, and we choose the winner. So to announce the winner for this month's presentation, the next slide. So the winner, once again, I think he's winning it the second time. It's Dr. Sumit. He is also from the ACTREC in Mumbai. He's an assistant professor. Congratulations, Dr. Sumit. Now I would request Nirav to present the pre-recorded video of the journal scan presentation.
Good evening, everyone. Thank you, Team Image, for this opportunity. The topic for journal scan for today is biallelic deletion 1p32 defines ultra high risk myeloma, but monoallelic deletion 1p32 remains a strong prognostic factor, published in Blood last month. So we know that myeloma is second most common hematological malignancy, and developments have led to survival benefit, but still high risk patients represent an unmet medical need. RISs included deletion 17p, 414 and 1416, but chromosome 1 abnormalities were not included. A recent study had confirmed the poor prognostic impact of deletion 1p32 as the second most adverse abnormality after 17p deletion. This study updated data on prognostic impact of deletion 1p32 in a large cohort of newly diagnosed myeloma patients, irrespective of treatment strategy. Coming to methods, over a period of 11 years, in the retrospective analysis from the IFM cohort, 2,551 newly diagnosed myeloma patients were included, who were followed up for more than 3 years or who had evidence of death or progression within the first 3 years of treatment. Baseline bone marrow samples were analyzed at a central lab where they were subjected to CD138 magnetic cell sorting, and only samples with more than 70% plasma cells were analyzed. These plasma cells were analyzed for cytogenetic abnormalities by either FISH, single nucleotide polymorphism arrays, or next generation sequencing, on the premise that all the 3 techniques are equally sensitive. Those SNP or NGS results, which were revealed 17p deletion positivity, underwent additional FISH to confirm the percentage of plasma cells which were positive, and deletion 1p32 was labeled when either FAF1 or CDKN2C genes were found to be deleted. On FISH, probes were used for gain 1q, deletion 1p32, deletion 17p, and translocation 414. Only a minority of patients had FISH results available for 1416 and 1420. The cutoff for 17p deletion was more than 55% plasma cells to be labeled as 17p deletion positive, whereas it was 30% for all other cytogenetic abnormalities. And subsequently, patients with deletion 1p32 were compared with those without. For statistical analysis, standard methods were used for categorical and continuous variables. Survival was estimated using the Kaplan-Meier method, and a multivariable analysis was performed for all variables which were significant in the univariate analysis. Coming to results, 11% of the whole cohort, that is 282 patients, had deletion 1p32. There was no difference with respect to the median age and gender distribution in both the cohorts. There was higher frequency of ISS3 and high-risk abnormalities like 17p deletion and TP53 mutation, 2.5 times higher as compared to the non-deletion 1p cohort, and gain 1q was found in 55% of the patients with deletion 1p. 76% patients did not have available data for 1416 and 1420. Therefore, the data for this was not available in majority of patients. When we look at patients who underwent a transplant, which is 134 patients, 50% of the whole cohort, majority of them received a triplet, that is a PI plus IMiD plus steroid backbone. The other half who are not eligible for transplant received either an IMiD or PI without anti-CD38, which means either a doublet or and IMiD or PI with cyclophosphamide dexamethasone, which contributed to the majority of patients. In transplant eligible patients, 42% patients received a maintenance post-transplant. Out of 282 deletion 1p32 patients, 253 were accessible for PFS and 226 for OS. When we compare the survival of deletion 1p in red versus the non-deletion 1p, it is significantly shorter, with a median OS of 49 months, that is 4 years, and a median PFS of 18 months, that is 1.5 years. When we look at only the subset of patients who underwent a transplant, the survival is better than the overall cohort, but still inferior as compared to non-deletion 1p32, where the median OS of deletion 1p is 67 months and the median PFS of 25 months. We know that from deletion 17p that biallelic inactivation of TP53 is more unfavorable than an isolated 17p deletion. Does the same thing imply for deletion 1p also? The answer is yes. Those with biallelic deletion 1p had the poorest survival with a median OS of 25 months versus monoallelic deletion 1p, which had a survival of 16 months. And the same is implies for PFS, with the biallelic cohort having a median PFS of 9.6 months versus the monoallelic, which had a PFS of 19.6 months. It is important to know that the monoallelic still fared poorly as compared to those who did not have any amount of deletion 1p32. When they compared the deletion 17p frequency in the biallelic versus monoallelic cohorts, there was no difference, possibly telling us that it was a biallelic nature which led to a poor prognosis and not the association of biallelic with 17p deletion. So if we rule out concomitant high-risk cytogenetic abnormalities with deletion 1p, does a poor prognosis of deletion 1p still stand true? And the answer is yes. If we remove all 17p deletion patients, still 1p patients who were deleted had a poor prognosis with respect to overall survival and progression-free survival. And when we rule out all high-risk abnormalities, which means 17p deletion, 414N, and 1q, it is important to know that 1416 and 1420 were not included as high-risk abnormalities. The median OS of those who don't have any high-risk abnormality is 80 months. Those who have 1 is 42 months. And those who have 2 or more is very less, that is 31 months. Whereas 80 months appears good when we compare with all other patients who do not have any high-risk abnormality and who do not have a deletion 1p32 also, still the overall survival and PFS of these patients is poor, which means that deletion 1p still stands as a prognostic matter of poor survival even after excluding all other high-risk abnormalities. On multivariate analysis, deletion 1p contributed to a increased risk of progression, which is 1.3 times higher, and increased risk of death, which was 1.9 times higher, similar to other high-risk abnormalities as well as ISS3 cohort. So the study confirms the adverse impact of deletion 1p32 in the largest cohort of newly diagnosed myeloma patients, and especially focus on deletion 1p32 because they previously studied 1p12, 1p22, 1p32, and found that the 1p32 contributes to poor prognosis. On 1p32 segment, 2 genes, FAF1 and CDKN2C, of which FAF1 initiates apoptosis. So its deletion would halt apoptosis and contribute to poor prognosis. Similarly, CDKN2C prevents cell cycle progression. So its deletion would imply more plasma cells entering the cell cycle and possibly lead to a more proliferative disease biology. We know that biallelic inactivation is because of deletion on one allele plus mutation on the other when it comes to TP53 mutation. But in this, it was double deletion and no evidence of mutation. This study confirms the adverse risk of deletion 1p in both transplant and non-transplant patients and reiterates the cumulative risk of multiple high-risk abnormalities as a factor for poor prognosis and the contribution of deletion 1p to poor outcome even in their absence. Coming to the limitations, the cutoff for abnormalities on FISH was 30%, which is higher than the EMN recommendation 20%. 3/4 of the patients did not have data for 1416 and 1420, which are essentially 2 high-risk abnormalities per se. And when we look at an overview of the study, with the non-uniform induction protocol, half undergoing a transplant with a PFS of 24 months, the other half not undergoing a transplant with a PFS of 18 months. Amongst those transplanted patients, 40% received limb maintenance, and those who did not were 60%. And when we compare the non-transplant cohort data with endurance trial, where they were treated with a uniformly with BRD or KRD, their PFS is much better than the non-ASCT cohort of the study. And the myeloma 11 trial, where all received line maintenance post-transplant, the PFS is much better than the transplant arm of the study, which possibly gives a food for thought that if we treat all of them with a VRD or standard triplet induction, followed by transplant, followed by line maintenance, it will possibly lead to more survival or a better survival as compared to what is shown in this study. Thank you.
Any comments from the faculty here?
You know, this was great again for you all to present this. We are going to re-look at redefining high-risk disease for myeloma. I think chromosome 1 abnormalities are becoming more and more of a high-risk signature. But I do think what you said was really, the presenter presented really importantly is, risk is a reflection of what you're doing for the patient. So, and I'm going to go back to a very old example. I'm going to go back to the example of deletion 13, right? Now, 15 years back, we used to call deletion 13 a poor prognostic factor. As soon as we started using bortezomib, that was no longer a poor prognostic factor. So prognosis changes with treatments. And this is why this chromosomal 1 abnormality and the cutoffs that we use for these is incredibly important. And what was highlighted so nicely in this journal scan was that different studies have used different cutoffs. And as a myeloma community, if we want to really define risk going forward, we need to know what the cutoff is. Is it going to be 20%? Is it going to be 30%? And why should it be different for the different chromosomal abnormalities? And those are things that we as IMS, so the International Myeloma Society, is going to come together to doing that. But this was good food for thought. I think chromosome 1 abnormalities will be considered to be high-risk features. What we use as cutoffs and what is the data that we will be using prospectively is something we still need to define. And I think that was highlighted in the paper. So thank you for doing that.
So to sum it up, I think this journal scan is more of a hypothesis generating and maybe in times to come a practice changing kind of inferences being made out of this study. That's what I would conclude from this journal scan. So I think we'll move on to the next session. That will be the quiz, the widely awaited one. We are close to 100 people have logged on now. We have a quiz time. And the next slide here. So, yeah, next slide. So the rules of engagement are very clear. So we have 5 questions here. One is going to be a trivia, then the 2 questions on the journal club and the journal scan, which was just discussed. And the fastest finger with the correct answers gets a voucher, a certificate. Yeah, let's start the ball rolling. First question. Which of these organizations or expert group on plasma cell dyscrasia uses an enzyme that is epicentered on the immunoglobulin structure? Is it the International Myeloma Working Group, the European Myeloma Network, the International Kidney Monoclonal Gammopathy Group, or the International Myeloma Foundation? You have 30 seconds to answer each question. The second question. Which one of the following is an incorrect statement based on the findings of the Frederick et al. Study? That was a journal club we discussed. And that's about the longitudinal profiling of T cell repertoire in myeloma patients receiving BiTEs. Statement A being the single cell T cell receptor tracing identifies conserved T cell responses to BiTEs. The clonal expansion of CD8 cells is an immunological driver of T cell exhaustion. Naive cells require additional MHC class II signaling. The abundance of exhausted CD8 clones predict response failure in myeloma. The next question is a very factual question. As per the study protocol in the journal club, which discussed T cell exhaustion and the exposure to bites, what clone threshold was defined to identify a large clonotype? Was it 10% clone size, 30%, 1%, or 50%? The next question would be from the journal scan which was presented. Which of these options is incorrectly matched positivity threshold and cytogenetic abnormality by fish as per the study on the impact of DEL1P32 in newly diagnosed myeloma? In fact, this was discussed threadbare post journal club as well. So for deletion 17p, 55%, for T414 and deletion 1p32, 30%, and gain 1p, 50%. You have to identify the incorrectly matched threshold. We move to the last question of the quiz. Which of the following statements is incorrect in the light of the findings of the study on the impact of DEL1P32 in newly diagnosed myeloma? The overall survival and PFS is significantly inferior compared with those without DEL1P32. Biallelic deletions of 1p32 dramatically worsens the prognosis with respect to a monoallelic loss. Melphalan-based autotransplant upfront mitigates the adverse risk conferred by 1p32 loss. Patients without high-risk cytogenetic abnormalities had a lower PFS and OS when they carried the deletion. Thank you. As Nirav compiles and finds out who is the one who has won this quiz, let me discuss the answers out here. The next slide, please. So the first question was about this organization, which has an enzyme which is centered on the immunoglobulin structure. The next slide, please. It is the International Kidney and Myeloma Gammopathy Research Group, previously erstwhile the MGRS group. And they were the group actually which unified together. There was a team of hematologists, nephrologists, nephropathologists, immunologists, and scientists who met around somewhere in the year 2012 once again to come up with criteria and guidelines about managing this MGRS spectrum of disorders. So the correct answer is the IKMG group, as you can see in their enzyme. The next slide. This was a question directly from the journal club, which was discussed. We must know that naive cells require MHC1 signals, and that is what let them differentiate upon T cell activation. So MHC class 2 signaling is not the mandate. So that was the correct answer. The next question was about defining the clonotype or the threshold of clonotype to define what is called as a large clonotype. Surprisingly, it is 1% and not 10 or 30. The fourth question was from the journal scan, which was presented. The thresholds here was uniformly 30% for everything other than deletion 17p. For deletion 17p, it was 55%. For the rest of the cytogenetic abnormalities, the threshold was 30%. So gain 1q was not 50%, but 30%. The last question. It was amply discussed and brought about by Dr. Sumit in his presentation that an upfront melphalan-based transplant doesn't mitigate the adverse risk conferred by a 1p32 loss. We don't have answers for this. So maybe in times to come, we may have to choose our therapy, which is both risk adapted and in fact dynamic risk adapted as per the cytogenetics and the response to therapy. Nirav, do we have the winner for the quiz?
Sir, it is Sumit Mirg itself.
So I think it's a double awardee this time. So congratulations, Dr. Sumit, for and what was the going score? Was it 5 on 5, 4 on 5?
So it is 3 out of 5.
3 out of 5. So that's excellent because this one was a tougher one. So can I have the next slide? The next slide, please. So it's my responsibility to introduce you all and invite you all for the next month's event. And we assemble here on 4th Thursday every month. All the myeloma novitiates and connoisseurs and all aspirants about myeloma. The day is 25th of May. Dr. Nupur Raje would again help us out, solve the mystery and share her experience on that particular topic being discussed. The standard time of 5:30 p.m. And before I hand over the dais to Dr. Das for the concluding remarks, let me express my gratitude to the mentors here. The next slide, please. Next slide. So we have these members of the scientific and the newsletter subcommittee, Dr. Das, Dr. Joseph John, Dr. Hari Menon. The next slide. And the enormous support we get from the faculty around the country. These names no longer need any introduction here. And the last slide. And my sincere gratitude to Dr. Nupur for sparing her precious time with us and augusting this audience with her remarks on the topic. Thank you one and all. With that, I will hand over the proceedings to Dr. Das for the concluding remarks.
Thank you, Arun. Actually, you have made my job very easy. And first thing, I want to thank Dr. Nupur for giving all these expert, comments and opinions. It's a great learning for all of us, and the work they are doing really it is, going to impact the management of multiple myeloma. And I thank Dr. Lingaraj for excellent presentation and Dr. Bausev for moderating it very excellently. And thank you, Dr. Pankaj, and thank you, everybody. We are finishing, I think, 15 minutes before time. It's all good. Thank you very much.
Thank you.
Thank you.
Everyone.
Thank you.
Thank you, Arun.
Thank you. Thank you very much.